The final category of hyperfluorescence to be considered will be hyperfluorescence caused by abnormal blood vessels. These abnormal blood vessels are immature and they do not have tight junctions, and therefore they will leak, and that will cause the hyperfluorescence. Different diseases cause neovascularization at different levels of the retina. Diseases causing widespread retinal ischemia will result in abnormal pre-retinal vessels. These diseases include diabetic retinopathy, branch and central retinal vein occlusions, and sickle cell retinopathy. Diseases causing subretinal neovascularization will include items such as age-related macular degeneration and any and all of the diseases which can cause breaks in Bruch's membrane. These would include diagnoses such as histoplasmosis, trauma, and angioid streaks. As you know, when there's retinal ischemia, the hypoxic retina generates vascular endothelial growth factor and other cytokines which stimulate new blood vessel growth. Now, the new vessels do not grow in the retinal tissue itself because that is already well formed. And because the VEGF is floating around the eye, the blood vessels will grow in the line of least resistance, and this will be preretinal or out into the vitreous cavity. Here's a very typical clinical and angiographic pattern of proliferative diabetic retinopathy. You can easily see the neovascularization along the supratemporal arcade and along the vein that extends from the nerve up towards 12 o'clock. There are also associated areas already of fibrosis in each of these areas. And then down at 4 o'clock, about a disc away from the nerve, you can also see some neovascularization. The fluorescein angiogram is very classic. There's capillary non-perfusion, and you can see this because the major area of the photograph on the angiogram is dark. Because the neovascularization does not have tight junctions, there is hyperfluorescence because the fluorescein is leaking out of the neovascularization into the vitreous cavity. This patient does not have neovascularization, but there is an abnormal retinal blood vessel, and this is a macroaneurysm. You can see this quite easily along the infratemporal arcade on the clinical photograph, and it's already beginning to fibrose. However, it is leaking a tremendous amount of serum, and you can see this by the very, very prominent circinate pattern around the macroaneurysm. On the fluorescein angiogram, you can see the dilated macroaneurysm quite well, and there's some hyperfluorescence there and a slight amount of hyperfluorescence from the leakage. This is another fairly typical photograph in case of non-proliferative diabetic retinopathy. These abnormal blood vessels are microaneurysms, and you can see these leaking on the fluorescein angiogram, mainly in the temporal macula. The two other entities of abnormal blood vessels at this point to be considered are telangiectatic vessels, as well as shunts and collaterals. The telangiectatic vessels may occur after vein occlusions, and the shunts and other collaterals can happen after branch and central retinal vein occlusions themselves. There's also entities such as Coats disease and juxtafoveal telangiectasia, which can give telangiectatic vessels as well. This is a 25-year-old male who was noted to have some abnormal findings on a routine examination. In the temporal periphery, you can see dilated telangiectatic blood vessels, as well as areas of capillary non-perfusion, and dilated capillaries in these areas. You can also see some larger aneurysms fairly easily on the angiogram as well. This patient has both diabetic retinopathy and a prior vein occlusion in the left eye. You can see some old laser marks inferiorly on the color photograph, as well as some dot and blot hemorrhages in the temporal macula. But the main thing to pay attention to is the sheathed vein inside the blue circle and the dilated blood vessels. If you look at the fluorescein angiogram, you can see some non-filling in the area of the collateral vessels, and also the collateral vessels are dilated, but they do not leak dye. Secondary findings on this are some hyperfluorescence from a scleral crescent, and then some leakage in the temporal macula from the diabetic retinopathy. Now, if you remember your basic retinal anatomy, you know that the blood vessels in the superior retina and the inferior are divided by what we call the horizontal raphe. If vessels cross the horizontal raphe, there has been a vein occlusion, and these are some collateral vessels. This patient had a vein occlusion sometime in the past, and if you look on the clinical photograph, there are some corkscrew blood vessels, mostly inferiorly, but they do cross the horizontal raphe going superiorly. The fluorescein angiogram shows these quite well. So the patient had a prior vein occlusion. Now, based on the collaterals, I don't think you can say exactly where the occlusion was, but you do know this patient did have a vascular event. This patient had a central retinal vein occlusion sometime in the past. On the color photographs, the blue arrows point to some large vessels on the nerve. And I point these out because these are collateral or shunt vessels. They are not neovascularization. The fluorescein angiogram shows not only the severe cystoid macular edema, but I want to point out that these vessels on the nerve do not leak. They are dilated normal vessels, so they still have their tight junctions, and therefore they do not leak. Hyperfluorescence may occur because of abnormal subretinal vessels. Exudative age-related macular degeneration is the main cause of this type of neovascularization. Other diseases, which can cause breaks in Bruch's membrane, such as histoplasmosis, angioid streaks, trauma, can have secondary subretinal neovascularization as a complication to this break. Now, although subretinal neovascularization can be divided into 4 types, in reality, retinal angiomatous proliferans is intraretinal and not pure subretinal, but it is listed here because it is a subgroup of age-related macular degeneration. Now, in aging degeneration, there's type 1 and type 2. An older term for type 1 was occult and type 2 was classic, and this was an angiographic definition. This is a 64-year-old lady who had had blurred vision in the right eye for about 3 weeks. On presentation, her vision is found to be 20/40. On the color photograph, you can see some subretinal fluid in the nasal macula. The early phase of the fluorescein angiogram shows minimal hyperfluorescence in the nasal macula. As the angiogram progresses, the choroidal neovascular membrane leaks fluorescein into the subretinal space, and this area becomes more hyperfluorescent. In the late phase, the dye is beginning to accumulate in this space. This is a type 1 or occult membrane, meaning the extent of the membrane is hidden by the pigment epithelium, and therefore you cannot see the edges as you can in a classic membrane. This is an example of a type 2 membrane or a classic membrane. The location of this membrane is between the RPE and the photoreceptors. Clinically, you can see this patient has a gray-green membrane with a halo of subretinal fluid. There's also some hemorrhage at the leading edge of the neovascular membrane. On the fluorescein angiogram, the membrane lights up early because there's no RPE in front of it to block the fluorescence. And as the angiogram continues, it becomes more and more hyperfluorescent. If you look closely at the early and mid phase, you can imagine a feeder vessel up about the 1 o'clock to 2 o'clock portion of this membrane, and the vessels are growing towards the fovea. This is a patient with type 3 neovascularization, or also known as retinal angiomatous proliferans. And this is a special type of macular degeneration where the abnormal blood vessels are actually intraretinal, and there's a connection between them and the choroidal circulation. This was first described in retina by Yanuzzi et al. In February 2012. Oftentimes, unlike other types of age-related macular degeneration, there are hard exudates and there may be some superficial hemorrhaging. On the fluorescein angiogram, there's diffuse hyperfluorescence, as one may see in an occult net, but there's also a hot spot, which is the site of the proliferans. And then also many times there is a pigment epithelial detachment, and you can see that on the OCT. And again, that's a triad. There's a pigment epithelial detachment, intraretinal neovascularization, as well as clinically hard exudates and a few superficial hemorrhages. Different diseases and degenerations can lead to neovascular membranes and fibrosis, and you can get vessels in these scars. Again, because they're not normal, they will leak some of the fluorescein, and then the fibrosis along with the vessels will lead to staining as well. Here is a very complex patient. This patient previously had an active choroidal neovascular membrane in the right eye, and it was treated with anti-VEGF, and that was several years ago. At this time, he has a yellowish lesion in the inferior right macula, and you can see on the fluorescein angiogram that this is hyperfluorescent. It is not leaking, but the vessels are staining the fibrotic tissue. So this patient had a choroidal neovascular membrane, treated very well, and he responded very well to the anti-VEGF treatment. The left eye is a different proposition. You can see in the superior macula a very white-looking lesion. This is not edema, this is not preretinal fibrosis, this is not cotton wool spot. This is subretinal fibrosis. You can also see various areas of subretinal hemorrhaging, which states that this lesion is in the active phase. The fluorescein angiogram shows blockage of dye from the hemorrhaging and hyperfluorescence from the new vessels in the scar, and some hyperfluorescence also from the staining of the fibrotic tissue accompanying this lesion. You can also get hyperfluorescence from tumor vessels. They can be either retinal or in the choroid. The two classic for the retina would be angiomas and also retinoblastomas. This is a case of a cavernous hemangioma. Clinically, it looks like large grape-like clusters in one area. While these vessels do not leak, there's hyperfluorescence simply because there's more dye in these vessels. At times, you can actually see a blood fluid level inside these aneurysmal dilatations, and there's not a lot of flow, so the dye tends to collect and become hyperfluorescent. This is a patient of Dr. Anthony Daniels here at the Vanderbilt Eye Institute. This patient has VHL with a hemangioblastoma in the far superior periphery of the right eye. The characteristic dilated feeding and draining vessels are clearly visible on the clinical photograph. Because these vessels do not have intact tight junctions, they will leak serum, and therefore this entire tumor complex will be hyperfluorescent. Tumor vessels can not only occur in the retina, as you've just seen, but also in the subretinal space. These can be from hemangiomas or from tumors such as a primary melanoma or metastatic lesions. This is another patient of Dr. Anthony Daniels. This patient has a choroidal hemangioma, and you can see it just supratemporal to the optic nerve. It has the typical light salmon-colored sub-RPE patch or lesion. The vessels leak and the tumor becomes hyperfluorescent as the angiogram continues. The OCT on the bottom right shows the elevation of the pigment epithelium. This is an old example of a melanoma. We don't normally take angiograms of melanomas at this time frame, but if the tumor is large enough, you can see the tumor vessels, and this is called a double circulation. The patients can develop metastatic choroidal lesions from a number of tumors. The most common one is lung. However, I've also seen metastatic tumors from breast as well as from the kidney and the prostate. This patient has a metastatic lesion from the lung. You can see that there's some hyperfluorescent spots. These are not the tumor vessels themselves, but it has damaged pigment epithelium, and you've seen some window defects and hyperfluorescence from that. Then overall, there's some late leakage from the tumor vessels, although you don't see the vessels directly.